Hello everyone, welcome to my lecture class. I am Dr. Ravi Roshan Khadka. I am a urologist and doing PhD in andrology now, and I am head of the clinical simulations and OSCE in Asia International University, Bukhara, Uzbekistan. I have a teaching and clinical experience of around 18 years, and let's start our discussion now. So today's topic of discussion is surgical anatomy of prostate. Let's see this question here. This is a very interesting question. This question asks about the precaution you should take during the TURP procedure. So let's see here. So why the surgeon should not dissect below the verumontanum? This is the question you have been asked. Okay. So to understand this question, the answer is here: external urethral sphincter. And to understand this question, let's see the anatomy behind this. Okay. Suppose this is the bladder. This is our prostate. And this is the urethra. So when we do TURP, we have to take care of one structure known as verumontanum. This is the verumontanum. And when we do TURP, we introduce our scope through urethra. Okay. And we cut the prostate chips like this. While doing that, we should not come below this verumontanum, because this outside the veru, there is muscle known as external urethral sphincter. So if you come down, there is chance of damage of this muscle, and if it is damaged, it will lead to urinary incontinence. That's why, see this question again, the verumontanum is a landmark for external urethral sphincter, which should not be damaged during TURP. TURP means transurethral resection of prostate for BPH. Okay. Now let's see the second question here. This is a very common question that generally asked in exam about BPH arise from which zone of the prostate. So you know the answer, I think. The answer is periurethral transition zone. This is the one, right? But let us understand the zonal anatomy. See this picture here. This is urethra, you can see. Okay. This is veru. And the prostate around the urethra, this one. Wait. The prostatic tissue around the urethra, this one is known as transitional zone, and from where BPH arise most. And you can see here there are two ejaculatory duct here. You can see this one, and the zone around this ejaculatory duct is known as central zone, and remaining the zone behind it is known as peripheral zone, and anteriorly there are some fibromuscular area known as anterior zone. So this is a general anatomy, and let me show you in the cut section as well. Okay. If you cut this prostate and see under the microscope, it is seen as, suppose this is the prostate. Okay. This is urethra. Zone around the urethra is known as transitional zone. There are two ejaculatory ducts behind it, and zone around the ejaculatory duct is known as central zone, some fibromuscular area anteriorly, and remaining peripheral zone. So see here, this is peripheral zone, this is central zone, and this all remaining area where the glands are not that much highly dense, this area is known as peripheral zone. And let me correct it. Okay. This is transitional zone. Okay. Now this is anterior zone. So the question that is commonly asked is, from which zone what type of disease occurs, right? So BPH can arise from any zone, but the most commonly arise from transitional zone. So don't forget this one for BPH. Okay. And whereas the cancer mostly arise from the peripheral zone. So CA prostate arise from the peripheral zone. This is a very common question asked in exam, and almost sure short question for exam. Okay, don't forget this one. Now let us see, there is one more picture here. Let me explain one thing to you. So this is the prostate. You can see prostate is lined by a fibrous layer known as fibrous capsule, This is the fibrous capsule, the blue one, which is a true capsule, and there's some fibrofatty tissues around it, okay, outside. This is a loose tissue known as false capsule. In between these two capsules, you can see there are some prostatic venous plexus. Okay, this is important. Later on, I'll explain why it's important. Now, see here, if the patient has BPS, suppose it start from the transitional zone, you know that, and start to grow peripherally, right? See here, peripherally, okay. And now you can see here, this black represent the BPH, that is a benign prostatic hyperplasia. Okay, the yellow represent the normal tissue, and you can see the blue one. So whenever the patient has BPH, that time the yellow tissue that you can see here, this yellow part, this one which is a compressed tissue due to the BPH, this compressed tissue is known as surgical capsule. Surgical capsule. So normally prostate has two capsule, false and true capsule, but during BPH it has an extra capsule which is a compressed tissue of prostate that lies between the BPH and the true capsule. Question is why we should know that. So the thing is, whenever we do open prostate surgery, at that time what we do, we cut the abdomen, we cut the false capsule, and we introduce our finger through this surgical capsule such that we can enucleate it and take it out. So this is known as Millin's prostatectomy. Millin's prostatectomy, which is an open technique of surgery. Whenever there is a prostate size more than 100 gram, we usually do Millin's prostatectomy. And for that reason, you should know that the space between the true capsule and the BPS nodule, the compressed tissue makes a surgical capsule, and that helps us on surgery. And this is the question asked in exam. What is surgical capsule? It's a compressed normal tissue between the true capsule and the BPS nodule. Okay. Now, see this question here. See, whenever you see the prostate here. Okay, this is urethra. You can see these are the ejaculate duct with seminal vesicles. Okay, fine. So see here, any lobe can get enlarged to compress the urethra, but mostly whenever the median lobe get enlarged, it has a higher chance of obstruction because the median lobe lies just near the bladder neck. Okay, this is the bladder neck. So the median lobe can easily protrude upward to obstruct the bladder outlet. That's why any lobe can enlarge in BPH, but if the median lobe is enlarged, then it can cause more obstruction. You can see in this picture as well. This median lobe is enlarged. It went inside the bladder, causing the bladder neck obstruction. That's why the median lobe obstruction is more common. Okay. Yeah, this is a very interesting question. The most common site of metastasis of prostate cancer is, right? Normally, we may choose lung as a choice, but here the answer is bone. Okay, let me explain why it is bone. First of all, you have to understand about the metastasis. Okay, so whenever there is any organ, I think you know this very well, the GI organ, the GI from the esophagus, stomach, intestine, up to pectinate line of anal canal, all the blood goes back to liver, right, via portal vein. That's why any cancer in this part of GI tract first go to the liver as a metastasis, as a rule. Okay, there are some exceptions, obviously, and whereas the non-GI organ like prostate, any other organ, the blood goes to, so non-GI organ, the blood goes to systemic circulation. Via there it goes to heart, and in heart it will not stay and it will go to lung as a first choice. So in any cancer which is not a GI cancer, it prefer to go to lung as a first choice, but here it goes to bone because the prostate here the prostate here is surrounded by those prostatic venous plexus, I've already explained, which is outside the prostate. Okay. So, if there is a cancer arise, these cancer may go to prostatic venous plexus, okay, and then may follow the normal route of inferior vena cava and to the heart and to the lung, right? It may follow this route as well, but there is an additional communication of the vertebral vein. These are internal vertebral venous plexus, okay, internal vertebral venous plexus. These are connected via additional vein known as Batson vein. Batson vein. That's why the cancer prefer to go via short route which has no valve and can easily involve the bone as a choice of metastasis. That's why this is a very common question in exam. If there is a prostate cancer, what is the most common way of metastasis? Answer is via Watson vein, it prefer to go to bone. And let me add one more thing here. Whenever cancer goes to bone, it destroys the bone by two techniques. One is known as osteoblastic technique, other is osteoclastic technique. Usually bone destroyed by osteoclastic technique, but here in cancer prostate, they make new irregular unwanted bone that destroy the bone or fracture the bone. So the cancer prostate causes osteoblastic damage to the bone, and this is also a question of exam. So don't forget this too. The choice of metastasis is bone, and the way to damage the bone is osteoblastic, also known as osteosclerotic technique of damage, right? So thank you for this short session of surgical anatomy of prostate. See you soon. Bye bye.